together. But I think in this patient in particular, I may have kind of seen if we could do pharmacotherapy a little bit better and kind of just treat his sinusitis a little bit better as well as his asthma. But I mean, that's what I would have done first. But I think the audience isn't necessarily wrong either, considering a biologic.
And Anju, what about his asthma? Do you think his asthma has been optimally managed, or do you think there are things that you would offer him before considering a biologic?
I think he was only on albuterol inhaler, if I recall correctly, right?
That's
so
correct.
I do think his asthma could be managed a little bit better even before starting biologic. I think in the long run, a biologic would be a consideration, but short run, when he comes to my clinic, I would start him on an inhaled corticosteroid long-acting beta agonist and consider giving him a course of oral steroids depending on how he has done previously and how many courses he's had. In the long run, though, surgery is definitely a possibility. He's never had surgery previously. But if his disease were to come back, which we suspect with him having aspirin-exacerbated respiratory disease, there's a good chance. So then I would have a low threshold for a biologic.
Sure. So suddenly, now there are two reasons in some ways to do some further oral corticosteroids. His nasal polyp suddenly seems to be poorly controlled. His asthma seems additionally could potentially use it. So in this patient's case, a short course of oral corticosteroids was prescribed. They switched him to a low-dose inhaled corticosteroid for his asthma. And for his nasal polyps, in addition to the oral corticosteroids, this exhaled delivery system, fluticasone, was advised. Patient was advised to stop using NSAIDs because of this concern for possible AERD. But 2 months later, the patient comes back. He reports that he is using his inhaled corticosteroid as well as his exhaled delivery system, fluticasone. But he found that as soon as he finishes oral corticosteroids, his symptoms returned and he's continuing to experience loss of sense of smell, difficulty with sleep. He still continues to have asthma exacerbations. Hospital pulmonologist has also switched him up to the long-acting bronchial agonist that Anju mentioned. And so given those additional tweaks to his medical management, now what is your next step in managing Josh's chronic sinusitis with nasal polyps, endoscopic sinus surgery, biologics, yet more oral corticosteroids, or aspirin desensitization? Okay. Audience wants to go to a biologic. I think that certainly is one of the options. He does have a number of comorbidities, including the atopic derm and asthma. Panelists, do you think, would you go to a biologic yet, or would you advise aspirin desensitization or sinus surgery? What would your bias be on this patient?
So, Bruce, I'll go first. I mean,
yeah.
I think for this patient, I would do sinus surgery. I mean, I am a rhinologist and I do lots of sinus surgery. But I mean, for this patient, I would do sinus surgery because I think it's got a chance of making his polyps better. And then by doing sinus surgery, we know that it also helps control his asthma better as well. So, in this patient who's never had sinus surgery, who has that big of a polyp, is not responding very well to medical treatment, instead of doing biologic first, I mean, biologic is not a bad option, and it is an option, but I would probably, in my hands, I would probably do sinus surgery first.
Sure. Anju, your enthusiasm for aspirin desensitization on this patient?
I'm not a rhinologist, so it wouldn't be in my hands, but it would be someone I'd send to you. I think he's never had surgery. So thinking of many things, including economics, I think surgery for almost everybody, unless surgery is a contraindication, I think one surgery is a good idea. So unless he's totally against surgery, I would say surgery. In terms of aspirin desensitization, it we typically think of it after surgery. It is something that's an option, but he's a hockey player. I wouldn't want to do aspirin desensitization on a hockey player because I'd hate for him to be hit by something and then go bleeding. And there are meta-analyses comparing biologics to aspirin desensitization. So if you had to choose between biologic or aspirin desensitization, I would choose biologic. But I think I would talk to him about it and consider suggesting maybe surgery for him.
Sure. All good points, and I think certainly in the current age, certainly I think later on we'll talk about shared decision making, but all of those things are certainly on the table for this patient and worthy of discussion. So certainly when we see patients with nasal polyps, it's important to remember that patients don't just have nasal polyps; they frequently have comorbidities that come with nasal polyps. The most common typically include asthma. The studies generally in tertiary care centers in Western countries find that upwards of almost 2/3 of patients with nasal polyps, especially those going to sinus surgery, have concurrent asthma. This is much more common than if you had chronic sinusitis without nasal polyps. Allergic rhinitis is also more common amongst the patients with nasal polyps, with about half of the patients having a history of allergies. And then aspirin-exacerbated respiratory disease is another comorbidity. Some tertiary care series report up to 30%. I would say in our center, it's about 15 to 20%. Sometimes if you're a referral center for AERD, your percent of your nasal polyp patients who have AERD tends to be higher. But studies do suggest that it's important to screen patients for this concurrent presence of aspirin sensitivity. It's not just aspirin, it's most NSAIDs. In Europe, that's why they call it NERD. In America, we call it AERD, partially because the acronym NERD in the US is not a particularly pleasant one. But we find that the presence of this comorbidity does confer some clinically useful information. We find that the patients who have AERD generally have worse asthma that's more severe, more difficult to control, have more mucus production, and perhaps more airway hyperresponsiveness. Patients with nasal polyps and AERD also tend to have worse sinusitis radiographically. Their mucin tends to be much more eosinophil rich, and they also have higher rates of smell loss. The medical management of chronic sinusitis with nasal polyps is certainly an area of evolving studies, but things that have shown benefit in the past are saline irrigation. It should be noted that this should be the high volume irrigation, and in fact the studies that show the benefit actually use the hypertonic solution. I know a lot of us tend to use just isotonic solution, but the studied use of nasal saline irrigation was hypertonic. There is not much benefit to just a saline spray. Intranasal corticosteroids certainly have utility in this condition, and especially this exhaled delivery system fluticasone, I would say, is something worth mentioning, and we'll go over that. Oral corticosteroids are also are helpful, but they tend to only relieve symptoms for a fairly short time before symptoms rebound, but they do have I would say, a fairly large magnitude of effect. Antibiotics for patients with nasal polyps, there's one small study showing a benefit of doxycycline, perhaps due to its ability to modulate Staph aureus, which is thought to contribute partially to CRS with nasal polyp pathogenesis, has been studied and shows a small benefit. I wanted to specifically mention this exhaled delivery system fluticasone, which is a method where you basically blow into this device. It takes advantage of the fact that when you blow into a device, it closes your soft palate and enables transnasal distribution of corticosteroids in the nasal cavity. This has been studied in some phase 3 clinical trials involving 323 patients with nasal polyps, and they used the device for 16 weeks. And it showed that the polyp size on average reduced by 1.3 points relative to 0.6 in placebo, which was statistically significant. polyps were eliminated in about a quarter of patients on the drug at 24 weeks compared to only 9% of patients with placebo. And this also resulted in significant improvements in patient-reported outcome measures. They used the SNOT-22 in this case and reduced need for sinus surgery in this study. And I think I will supposed to go until slide 25, I think. And so endoscopic sinus surgery is certainly another option for these patients. And what studies show is that endoscopic sinus surgery does drop your radiographic severity. Going from, there's a study that we did. We had patients about at the time of surgery and follow up with them about 3 years after surgery. They were invited in to participate. What we find is radiographic severity is measured by this modified Lund-Mackay score. Even 3 years after surgery drops by about 1/3. And the SNOT-22 scores are durably reduced by about half. Certainly one can argue whether 3 years is long enough follow-up, but certainly at a fairly intermediate term follow-up after endoscopic sinus surgery, symptoms are improved after surgery. There's also now one randomized controlled trial that compared continued medical management against endoscopic sinus surgery. So it randomized patients to either of these two treatment groups. This was done in the Netherlands. And what they did was if a patient was eligible for surgery, they asked them to agree to be randomized to sinus surgery up front versus continuing with their medical management. This on the table on the left says that basically they were fairly well matched in terms of Lund-Mackay score, SNOT-22 scores. And what the study showed was that with sinus surgery, which is in green, you have a fairly quick improvement in symptoms. Medical management at about 12 months approached about the same symptom control as endoscopic sinus surgery. But there should be some caveats noted about this study, which is that they use an intention to treat analysis such that the medical management group could switch over to endoscopic sinus surgery. And in this study, about 20% of them did so within the 12 months of the study. And the second issue to note is the medical management group also used more oral corticosteroids, about twice the amount, about 600 milligrams versus about 300 milligrams in the group of patients who were randomized to the endoscopic sinus surgery group up front. So those are the caveats, but there is now this randomized controlled trial. All right, I'm going to let whoever is supposed to take on next.
So I'll take on next, and we'll go to a case, who's Martha, who's a 41-year-old woman. So Martha is a 41-year-old female with asthma and allergic rhinitis. She presents to your clinic with nasal congestion and a decrease in sense of smell. On exam, you notice she has bilateral nasal polyps. Her asthma is not bothering her. Her past medical history, as I mentioned, is asthma and allergic rhinitis. She's allergic to dust, mite, and molds. Her FEV1, her forced expiratory volume in 1 second, is 69% predicted, so about moderate severity. So oral corticosteroids were prescribed to Martha. However, her symptoms came back as soon as she finished her course. The steroid course really bothered her as well because it kept her up at night, which made her unproductive for work. As an allergist, I got a CT scan, and here's her sinus CT scan showing significant opacification. So she was sent to ENT for evaluation of surgery, and another option was possible biologic. So what would you do on Martha? Would you consider sinus surgery for her, biologic, unsure between surgery or biologic, or another treatment option? Let you guys vote. All right, so 75% of you guys suggested surgery, 25% suggested biologic. In terms of our panel, Dr. Hahn, Joe, what would you suggest?
Yeah, so I hate to sound repetitive, but I'm gonna say I'm gonna do sinus surgery on this guy, this person, this patient, because I don't think the patient ever had surgery. And it's kind of interesting. The patient had a history of asthma, allergic rhinitis, and what I tell my pulmonologists is if any of your patients who has asthma has nasal symptoms and if they have sinusitis, nasal symptoms, I would say you got to consider sinusitis. And if they have a loss of smell, you got to consider nasal polyp. And, and if she's not getting better with medical treatment, I would do surgery. And so sorry to sound repetitive, but that's what I would do.
How about you, Bruce?
Yeah, I think I'd agree. Her other comorbidities on that severe and certainly as that study showed, some patients, on average, the patients get significant symptom relief and even radiographic relief, even years after sinus surgery. And I think the management of the patients, especially with topical treatments, becomes improved after endoscopic sinus surgery.
And I think that's what the audience thought, most of them as well. So we'll move on to biologic treatment. And so just a little bit on pathogenesis. This is a really busy slide. Let me just summarize it for you. Our airway epithelium on top is faced by different insults, including bacteria, allergens, viruses, fungi, etc. The epithelium then releases what we think of as alarmins, TSLP, IL-33, and another one called IL-25. TSLP, IL-33, IL-25 then lead the ILC2 cells that are in the middle of the screen to release type 2 cytokines, which are even more down below a little bit in the red, IL-5, IL-4, and IL-13. In addition, the alarmins lead the Th0 to become Th2 type of T cells, which also lead to release of the cytokines. I think in the center of the screen, the cytokines that we all think of, which lead to type 2 inflammation, are the ones that are targets of the biologics we'll talk about. IL-4 and IL-13 play a role in causing the B cells to release IgE, the allergic antibody, which you can see on the screen on the right-hand side on the bottom. IgE can sit on mast cells, lead to mast cell degranulation. IL-4 and IL-13 also play a role in airway remodeling, mucus hypersecretion on the middle bottom. And then IL-5 is the growth factor, survival factor for eosinophils, which we know play a big role in type 2 inflammation. So the different biologics that we have that are approved for nasal polyps in the US include dupilumab, which targets IL-4 and IL-13 based on the phase 3 trials, Sinus 24 and 52. They had a large number of patients in there, more than 600 some patients. Omalizumab, which targets IgE, is also approved for nasal polyps based on polyp 1 and polyp 2. And then mepolizumab targets IL-5, targets the eosinophilic inflammation. It also is approved for nasal polyps based on the phase 3 SYNAPSE study. And let's talk about these a little bit more. Let's start with dupilumab. This is from Sinus 24 and Sinus 52 phase 3 studies. Dupilumab is in the green, placebo is in the grayish triangle. It's important to note that all patients were on topical nasal steroids in both these studies, and in fact, in all of the biologic studies. And when you look at one of the primary endpoints, change in polyp size, dupilumab reduces it quite significantly by week 4, you can see on Sinus 52, and by week 8 on Sinus 24, continued reduction. And in Sinus 24 in the left, once dupilumab is stopped at week 24, then polyp size tends to come back. And in Sinus 52 on the right, they are showing 2 arms of dupilumab. One is every 2 weeks in lighter green, and one is every 2 weeks till week 24, and then every 4 weeks. And both of them did better than the placebo arm in terms of polyp size reduction. The other co-primary endpoint was nasal congestion, a symptom that's very bothersome to patients with nasal polyps. In both sinus 24 and 52, you could see dupilumab in the green did better than the placebo, which is in the darker gray color. And in sinus 24, you could see once dupilumab is stopped, congestion comes back. So it works while you're taking the treatment. Here is polyp 1 and 2, the omalizumab study. On the left-hand side is nasal polyp score. Omalizumab is in green triangle as well as the red square. It does better, significantly better. Polyp size goes down by about 1.25 compared to placebo. Again, everyone was on nasal steroid spray. The other co-primary endpoint for polyp 1 and polyp 2 was congestion. And omalizumab in green and red did better than placebo, which were in yellow and orange. And this was these were 24-week studies. And then finally, mepolizumab, which targets IL-5 in SYNAPSE study. On the left-hand side, you could see total endoscopic nasal polyp score went down by about a median of 1. Mepolizumab is in blue, placebo is in the gray circles. And the nasal obstruction visual analog score, another way of looking at nasal congestion, mepolizumab did better than placebo. So, we have different biologics, and there are no head-to-head comparison studies. There are a couple of meta-analyses. This is one that was published recently and is being used as part of our practice parameters that are coming out in the US for treatment of nasal polyps. In this study by Oikman and colleagues, they compared the different biologics to aspirin desensitization. And let me go through it a little bit with you. On top, they compared different outcomes. One is patient-important outcomes, which included quality of life, symptoms, sense of smell, decrease in need for surgery or steroids, and also looked at adverse events. And on the right-hand side are the surrogate outcomes, which are, still important, but may not be as important to a patient per se, are the nasal polyp size and CT scores. And in this table, the darker green color is among most beneficial and red is among most harmful. So for example, if you look at sense of smell, which is the fourth column, dupilumab is in dark green, omalizumab, mepolizumab, and benralizumab, which is not approved for nasal polyps in the US, are in lighter green, suggesting dupilumab is among the most beneficial. If we look at the adverse events, they all that are in blue have very low risk adverse events. The one in red is aspirin desensitization, which has higher risk in terms of GI adverse effects and bleeding. Well, let's look at one more. When you look at nasal polyp size, dupilumab, which is in dark green, reduced polyp size the most compared to omalizumab and mepolizumab, which were second. And benralizumab and aspirin desensitization, which I'm having a hard time saying it today, were among least beneficial or not clearly different from placebo. So it's a busy slide, but it gives you a good way of comparing the different treatment options. And our European colleagues actually have come up with criteria in how to decide a biological treatment. And so based on euphoria, they recommended biologics if a patient has bilateral nasal polyps, so makes sense. If they've had history of surgery or not have had a history of surgery, then they recommend if you've had surgery, 3 criteria. If you've not had history of surgery, then 4 criteria. And the criteria would be things like evidence of type 2 inflammation, need for steroids in the past year, impaired quality of life, loss of smell, or comorbid asthma. So again, all of these things make sense as when you decide to choose a biologic for a patient. Our European colleagues also in the EPOS 2020 steering group had indication for biologics which were similar to euphoria. Here they again said bilateral nasal polyps and said 3 criteria, mostly criteria that suggested someone has severe disease and or type 2 inflammation. So use of steroids, impairment of quality of life, loss of smell, or comorbid asthma. As we know, these biologics are approved for comorbid asthma, and comorbid asthma, as Bruce talked about, is quite likely. And with this, I'll pass it on to Joe, since he can discuss more of our European guidelines that were published last year.
Thanks, Anju. So this is a disciplinary approach to the management of treatment algorithm. And this is kind of like the second half. So we had experts from the 5 national organizations that take care of patients with CRS with nasal polyp. And this is the second half. The first half was, you make sure you diagnose them appropriately with nasal polyp, give them topical steroid and maximize the topical steroid for the treatment of nasal polyp. And after we maximize the treatment of nasal polyp with topical steroids or short bursts of steroids, the question was, what do we do next? And then the question was, if they failed that, the experts felt that majority of the patients who failed topical steroids should undergo sinus surgery. And I think that's something that you've heard today as well. But we understand that there are some patients who just don't want surgery, who can't have surgery, or patients who are poorly controlled in terms of their asthma that are not even surgical candidates as well. Sometimes these patients should not undergo surgery and maybe undergo biologic therapy first. And if they do have surgery, and after the surgery, you need to have postoperative medical treatment. Most commonly, they're usually topical steroids. And if they have surgery and have had medical treatment after the surgery and still have polyps come back, these are often patients with the severe nasal polyps that we've talked about today. And a lot of these patients, as you've heard today, have asthma. So I think it makes sense to have a multidisciplinary approach, whether it be working with the allergist, the ENT, and the pulmonologist together, trying to make a good decision on what's best for the patient. And this is where, there are a lot of different options. There have been, as you see there are a lot of different options that we have for our patients: biologic, revision sinus surgery, desensitization in patients who have aspirin intolerance, steroid sinus implant, and even short bursts of steroids. And so those are all things that I think we have to discuss with our patients, ask our patients what they want to do, and then kind of go on from there. Now, one of the questions that comes up is if they had surgery, failed, and polyps came back, and you have to do a biologic, how long should you consider? And I think what we're finding out is that a lot of these evidence-based papers or publications that are coming out are agreeing that 6 months seems to be an appropriate length of time to see if patients have responded well to a biologic. And in fact, I think we're seeing that a lot of payers are seeing that today. So in fact, I had a patient today who had polyps, bad aspirin triad, gave him a biologic, and the insurance is making her come back and see me every 6 months to make sure she's had a good response. So I think that's kind of what we're seeing. And so I like to then kind of pivot and present a case to you all and to the panelists. So we have a patient, Dan, 53-year-old man, history of allergic rhinitis and chronic sinusitis with nasal polyp. I think this is a very typical patient that we see. And so this patient has allergic rhinitis and nasal polyp for a long time. And it's not uncommon that men often have allergic rhinitis and don't have asthma. It's usually the women that are a little bit higher in having asthma and nasal polyp. Men tend to have allergic rhinitis and nasal polyp and a little less likely to have asthma. And so this patient has been on topical steroids, the spray, the exhalation delivery system, short bursts of steroids. And even with that, the patient on post-treatment CT of the sinus shows pansinusitis. And in fact, 9 months ago, he had sinus surgery and the polyps came back. So what that tells me right off the bat is that within less than a year, the polyps are starting to come back despite sinus surgery and medical treatment. And so, the patient wanted, something to treat. And so we gave him the systemic steroids and he had improvement of his symptoms of congestion and loss of smell. But over time, his symptoms started coming back. And then reviewing that post-treatment CT of the sinus, all the sinuses appear to be opacified and the openings of all the sinuses are open. So for this patient, what would you do? And so, I guess actually before I do that, let me ask this question to the audience. So after sinus surgery, what do you provide to the patient? Do you do topical steroid spray, steroid irrigation, or others such as steroid implants, maybe even exhalation delivery system. So those are some of the options that we have. So what would you provide for your patient? And so we'll give you a couple of minutes to kind of decide. And so while we're waiting, hey, so Bruce, what do you provide for your patients after the surgery?
Either the exhaled delivery system or the corticosteroid irrigation. I think some patients, just coverage-wise, it's easier to get one or the other, or sometimes just depending on their lifestyle. I think people who travel a lot struggle to have availability for irrigation consistently, and sometimes on those patients, the exhaled delivery system is better. I use budesonide or mometasone. I think budesonide's more available as a prescription, whereas mometasone usually has to go to a compounder.
Okay. So let's see what the audience says. So let's look at the audience response. So steroid irrigation is what they picked. So interesting. And so, Anju, what do you think about that? Do you think steroid irrigation is your main treatment options after surgery, or what else do you consider?
I think like Bruce said, it post-surgery, either steroid irrigation or exhalation delivery system, fluticasone, either one is fine. Sometimes people don't keep up with the rinses, and EDS flu seems to be a little bit easier, but it also depends on approval by insurance.
I have one question for you, Anju. So what about leukotriene modifier for our patients with ARD or aspirin triad? Is that a consideration?
I think a leukotriene modifier is a consideration, especially for AERD patients. They benefit some people, and some people swear by it, by other people don't. So it's a small number of patients. We're also limited in that there is a black box warning. So I do always tell my patients that. But yeah, it's in an AERD patient. I would consider it as part of a medical therapy. It alone, though, never seems to be enough.
Yeah, a very good point. And so I'd like to ask one more question to the audience. So for Dan, the person we just talked about, let's go to that question. So how would you treat Dan? Would you do a revision sinus surgery on the patient? Would you consider doing dupilumab, mepolizumab, omalizumab, or are there other treatment options you would provide to the patient? So we'll wait a couple of minutes to kind of think about, and get the audience to respond to the question. Okay, there's our response. So surprisingly, a lot of the patients, a lot of the audience wanted dupilumab. And Bruce and Anju, what do you think?
I think it's a reasonable choice to me. I mean, my sense is based on the data Anju previously presented. It does seem to be a biologic that, at least for the nasal polyp end of things, has a larger treatment effect. And additionally, I think, while revision sinus surgery can always be considered, as long as, the sinus surgery, like you mentioned, sounded like it was fairly well done, and most of the osteo were actually surgically open. And if he, only had sinus surgery 9 months ago, I think the patient might be rather discouraged to consider sinus surgery.
Yeah, Anju, any other points you want to make?
No, I think I agree with Bruce that I wouldn't want to get surgery again if I just had surgery within the past year. Dupilumab, it did seem, based on meta-analyses, that seems to do better. Now, if there were comorbidities, such as if the person had chronic idiopathic urticaria, maybe I would consider omalizumab, since that's approved for that also. Or if this person had some significant eosinophilic pneumonia or hypereosinophilic syndrome with nasal polyp, then maybe I would consider mepolizumab. But otherwise, I think dupilumab seems like the right choice.
Yeah.
If it's just asthma alone, Anju, are there any specific asthma characteristics that would sway you to choose one other biologic over another say, over dupilumab?
If this person just had asthma, then, other things I would look at too, then really no, if he had very eosinophilic type of asthma, I might switch. I would consider mepolizumab. If it was a young kid with very allergic type of asthma, I would consider omalizumab with shared decision making if a parent thought that maybe a biologic being around the longest was the safest. But I think, dupilumab would be an option too. That asthma there are other things that'll help us decide eosinophils' allergic status, but dupilumab would work with allergic status too. So really, and what is covered by insurance often drives us.
That seems to be a big factor.
Because asthma exacerbation decreases clearly around 50% for dupilumab, mepolizumab, and just a little bit for omalizumab. And they all decrease oral steroids, except omalizumab in its study didn't show that.
Interesting. So great points. And so, and I think, this is from the paper from the Galen Network, in which they talk about how do we treat patients with nasal polyp. And I think this is kind of consistent with what we've seen earlier with that multidisciplinary approach for patients with nasal polyp, where we really want to maximize topical steroids, use saline irrigation, and maybe short bursts of steroids. And if they fail that, do surgery. And then, and if they do fail surgery, certainly consider those options that we've talked about before. And then, we talked about using topical steroids, after sinus surgery. And this is a study from Australia. It's a small study in which they looked at patients comparing nasal steroid spray versus corticosteroid irrigation. And not surprisingly, patients who had the steroid irrigation did better, a little bit better than those who got the steroid spray. And that makes a lot of sense. It's not that topical steroid doesn't work. It just has to get to the place where it needs to be, where the polyps are at. And that's why it makes sense that steroid irrigation should work a little bit better than steroid spray. And then, and this is, I think, a very interesting table. What this does is it looks at patients with chronic sinusitis with polyps and their comorbidity. So if you have chronic sinusitis alone, meaning no asthma, no aspirin triad, the time to do revision sinus surgery and the time to have revision polyp is a long time. It takes about 20 years. But if you have chronic sinusitis with nasal polyp, it could be a lot faster. So the rate for revision sinus surgery is 11 years, while for rate for recurrence of nasal polyp is as early as 4 years. And I think the one that's probably the worst that we commonly see is chronic sinusitis patients that have ARD or aspirin sensitivity or aspirin triad, depending on what your specialty is. And these patients, you could see that the median age is, median years for revision sinus surgery is 7 years. And I've seen those numbers even go down to 3 years. And you see that the median years to recurrence of nasal polyp is less than a year. So I don't think that is surprising information for any of us. And as you heard earlier, one of the questions that comes up is, we know that dupilumab is effective in our patients with nasal polyp, but, does the number of sinus surgery affect that? And how long ago you had the sinus surgery affect that? And it shows that it doesn't matter. So I think this is a nice, I love forest plots. It makes things that are complicated information and distills it down and makes it very easy to understand. And so what this tells us is patients, it tells us the number of sinus surgery you had on one side and the time, how recent the sinus surgery was versus, the placebo versus the treatment group. So if it's left of that line, that means that dupilumab has workers, the better. And so what this tells us, it doesn't matter if you had no surgery or 1 or 3 surgery, it doesn't matter. They seem to do well. And in fact, patients who had more surgery, maybe meaning that these are more severe patients, tend to do maybe a little bit better, just based on the average numbers. And if you look at patients who've had recent surgery, it looks like just on the nasal polyp score that the ones who had a more recent surgery did better. And what that may reflect is patients with more severe disease may do a little bit better on dupilumab, but overall it's not statistically different. But good graph to kind of summarize that dupilumab, regardless of how many surgeries you've had or how soon you had surgery, it seems to work. And so, and then I think this is an interesting graph. And so what this tells us is that, if you had multiple sinus surgery, how much improvement do you get in your quality of life? And what this tells you is after one sinus surgery, patients do very well and have a good response. But as you have more and more sinus surgery, it seems to the response of improvement seems to be a little bit less and less as you go along. And I think one thing that I think you heard Bruce say is not just so much the sinus surgery, but the appropriate and making sure that all the sinuses are open. And I think that's a very important point to make. And so, in summary, what we've seen is that chronic sinusitis with nasal polyp impacts the patient's quality of life and has a huge economic burden, not only just to the society, but also to the patient as well. And there are multiple quality of life measures that are available that we can use for our patients with nasal polyp. When you look at the use of systemic steroids, the adverse effect is high. And I think the more you use throughout the lifetime of the patient, the higher the adverse effects associated with that. I think there is a consensus that that you've seen tonight, where where biologic plays a role in relationship to surgery or other treatment options that are available for our patients. And as you heard tonight, Anju listed 3 biologics that have been FDA approved in the U.S. for management of chronic sinusitis with nasal polyp. And in the absence of head-to-head trials, it's hard to know which one is better, but there are some data that seems to show that it works, that one biologic may be a little bit better. But currently, there is an ongoing trial right now that is comparing omalizumab to dupilumab. And so I'm curious to see what that will show. And so with that, we have a few minutes left for some Q&A. And so if you have any question, feel free to type that in the question box or the chat box. I'll be monitoring it to see if there's any questions for our panelists. And so there's, so you can ask the questions on the chat box or the question box. Okay. So if you have a question, click on the bottom of below the slides. I'm sorry? So it looks like there's one question that did come up. And so the question is, what do you recommend after failure of endoscopic sinus surgery? So Anju, why don't I ask you first? How would you respond to that question?
I think that's a really good question, and it's similar to the case you presented. If someone has disease after they've had surgery, one of the first things I would think of, depending on where they had surgery, is to make sure they had the appropriate or right kind of surgery. So I would consider having them seen by one of my rhinologists I work with. If they have significant disease, was the surgery enough? If they've had the good kind of surgery and disease comes back, like we see in some patients with comorbidities such as AERD, I think that's when a biologic is a consideration, especially for diseases, for things like, asthma, AERD. If they have other comorbidities, then I think biologic is what I would think of next. I would make sure they have standard of care treatment going on with topical steroids, both for their nose as well as for their lungs.
Okay. What about you, Bruce?
Yeah, I think, firstly, a discussion with the patient about what failure means to them, just because there are some things that perhaps were unrealistic or perhaps not achievable for patients. I know I had a patient, we had a discussion about his definition of failure was that he never got a sense of smell back after sinus surgery. But at the same time, he was the kind of patient that even with courses of oral corticosteroids, he never got his sense of smell back. And endoscopically, his olfactory cleft was actually relatively clear. He did have some small polyps, but they were not olfactory in location. But he was trying to get his sense of smell back. But I think certainly making sure that what the patient perceives as a failure is something that any of the treatments you offer them can remedy is also important. But if it is a failure, as in bad polyps coming back, patient's very symptomatic, and you agree that the exam supports the symptoms being primarily attributable to the nasal polyps, I do think that the biologics are a nice new tool for patients.
Yeah, and I think, Bruce, you put a really important point. I mean, the patient perspective and, what the patient thinks is important and what they define as a failure is very important, because sometimes it may be different than what we would consider. Because for me, a lot of times is doing a nasal endoscopy and the sinus is looking pristine, but that may not be what the patient would consider as success. And so I think that's a very important point. And one of the things that have come up is, what about, looking at biomarkers? When do you consider that? Because, I think do you ever look at biomarkers to decide to see whether or not the patient has failed surgery? So do you ever consider looking at different biomarkers that are, so like, for example, like total IG, blood eosinophils, FeNO, or do you ever look at any of those things, Anju?
I don't think so. I put everything in together. I mean, I won't say I wouldn't look at any other things that go hand in hand. So, for example, if someone has had surgeries, complaining a lot, and has disease, it's easy for me to check because many of these people have asthma and polyps. So in clinic, I would do same as you do endoscopy and say, oh, I don't see much polyps in there, but I know you don't smell, and that may just be you might not ever smell. But for asthma, I could do a spirometry. And if their spirometry looks good and they're complaining of a lot of lung symptoms, I might say, this doesn't make sense. And if they're still complaining a lot, I might check eosinophils. And if eosinophils are really high in the blood, then I do think, yeah, there is inflammation. But those people, what biomarkers do we have? Really, blood biomarkers are the main ones we can clinically use, unless someone's had surgery and had high eosinophils in their pathology. So yeah, if the eosinophils are very high in pathology from surgery, if their blood eosinophils are very high despite surgery and they're complaining a lot of symptoms, it makes me think, yeah, they have inflammation and more treatment is necessary. But biomarkers alone don't do it. It's the patient's history, exam, and biomarker, and the supporting biomarkers we have currently.
Okay.
We've had an interest in nasal biomarkers, and certainly in mucus, we do find that nasal biomarkers do relate fairly well with objective measures, so the ones that clinicians use, endoscopic measures, radiographic measures. Especially radiographic measures are, I would say, quite strongly correlated with nasal biomarkers. But patient-reported measures do correlate, but the correlations tend to be quite weak enough that I'd say it's hard to use how a patient reports a symptom clinically to say, okay, you must have this much type 2 biology. As a plug, I actually think the blood biomarkers are actually most useful for your patients without nasal polyps, because there you don't have indicators of type 2 biology to guide you as to what type of inflammation they have.
Yeah, if we can get mucosal biomarkers, I know, Bruce, you're working on some, that would be ideal. I mean, I do use a lot of blood eosinophils, mostly because, some of these patients they're not that common, but those are the ones that we worry about. Those with bad sinuses, bad polyps, bad asthma, who might be potential EGPA, for example. It always sits in the back of our head. So I do check those things, but everything together helps guide our care more, I feel.
Yeah. So there's a couple of questions that have come up, and I'm not sure if we're going to be able to go through both of them, but one of the question is, what is your preferred nasal steroid irrigation? And so, Bruce, what is your preferred nasal steroid irrigation?
The one that patients will actually use. And that use just depends on what's the I guess a quick screening set of questions is how much do they hate irrigating. The ones who just hate irrigating, usually I'd say the exhale delivery system's better. The ones who don't mind irrigating, then sometimes looking at the entrance helps you figure it out, because I would say the government payers still don't cover the exhale delivery system methods. Budesonide is available as a prescription, and the compounders, variably take insurance. So I'd say the ability to get something covered is becomes the main consideration.
What about you, Anju? Do you have a preferred nasal steroid irrigation?
No, I agree with Bruce again. It depends on what patients want. We talk about shared decision making. They're okay doing irrigation with large volume, then budesonide sometimes is easier for me to get from just regular old pharmacy. But if they would rather, we'd almost always try EDS flu as well, especially because we're able to get it covered through their specialty pharmacy quite well.
Yeah. And, I was just going to add to what you guys were saying, because I think this is probably going to be the closing statement, is, that, it's not just steroid irrigation. I would say any type of topical steroid delivery. And, what I've noticed is people who don't like sprays, like the steroid implant, so they don't have to do the sprays or irrigation. And, the exhalation delivery system and the budesonide irrigation, I actually often will give it both to the patient and tell them, try this and try that, and then you tell me what you like. And so if they don't mind doing the irrigations or the exhalation delivery system, I just give them options, and they'll come back and tell me what they like. And so with that, it looks like we are at the end of our presentation and program. So thank you for your participation, and we will be sending you for evaluation of the virtual program. And thank you for joining us tonight. And thank you to our panelists, Bruce and Anju. Wonderful job.